Today, we delve into a compelling clinical case involving a 55-year-old man presenting with symptoms indicative of a complex endocrine issue. For 1 year, this patient experienced decreased libido, erectile dysfunction, and persistent fatigue, significantly impacting his quality of life. His medical history revealed opioid use disorder, for which he was on methadone, but no other medications were noted. A physical examination showed normal findings with a BMI of 25 and a normal genital exam, yet his morning testosterone levels were initially low. Initial workup confirmed a repeat total testosterone of 140 nanograms per deciliter at 8 a.m., which is significantly low. Further tests showed FSH at 2.1 milliunits per milliliter and LH at 1.4 milliunits per milliliter, both within the low to normal range, alongside a mildly elevated prolactin level of 18 nanograms per milliliter. Crucially, a pituitary MRI was normal, collectively suggesting secondary or hypogonadotropic hypogonadism. Considering the differential diagnosis, primary testicular failure was ruled out due to the low LH and FSH levels. A pituitary tumor was also excluded given the normal MRI findings, eliminating this as a cause. While hyperprolactinemia was present, its mild elevation suggested it was likely secondary rather than a primary issue. Chronic illness or obesity were not factors in this case, as the patient's history and BMI were within normal limits. Medication-induced causes, specifically his methadone use, emerged as a significant consideration. Depression or psychogenic erectile dysfunction were also considered, but the organic nature of the symptoms pointed elsewhere. The diagnostic reasoning centered on low testosterone combined with low or normal gonadotropins, indicating central hypogonadism. A normal pituitary imaging further suggested hypothalamic suppression rather than a pituitary lesion. Opioids are known to inhibit GnRH pulsatility and increase prolactin, leading to decreased LH, FSH, and, subsequently, testosterone. Therefore, the final diagnosis for this patient was opioid-induced secondary hypogonadism. Ideally, management involves discontinuing or tapering opioids, which can lead to recovery of gonadal function. However, if opioids are medically required, such as for methadone maintenance, testosterone replacement therapy is indicated. Before initiating therapy, it's crucial to check hemoglobin and hematocrit levels and assess PSA and prostate health. Patients must be monitored for both therapeutic response and any potential adverse effects of the treatment. After 3 months of testosterone replacement therapy, the patient experienced significant improvements. His libido and energy levels improved, erectile function was restored, and his overall mood and quality of life were enhanced. The key takeaway is to address the underlying opioid effect and provide testosterone replacement if opioid discontinuation isn't feasible. Chronic opioid use suppresses hypothalamic GnRH, leading to secondary hypogonadism. Mild prolactin elevation is common in these cases and typically does not indicate a prolactinoma. A normal MRI does not rule out functional hypothalamic suppression, which is often the cause. It is vital to screen for hypogonadism in symptomatic men on long-term opioid therapy. Finally, testosterone therapy effectively restores function when opioid discontinuation is not a viable option.